Okay, let's talk about polycythemia vera. So polycythemia means increased number of RBC mass. Therefore, there is increased RBC mass, increased plasma volume, and decrease in EPO levels, erythropoietin's level, and decrease because of negative feedback from the RBCs towards the kidneys. EPO tries to increase the number of RBC, but the RBC number is already increased. Therefore, it inhibits EPO levels. Polycythemia vera can be differentiated from secondary polycythemia by the presence of leukocytes. So polycythemia vera and secondary polycythemia must be differentiated. See, polycythemia vera, secondary polycythemia, if there is number of RBCs, more number of RBCs because of an infection, let's say, then or because of dehydration, let's say, then there is also increased number of WBCs, that is leukocytosis occurs, and the increased number of platelets as well, and with splenomegaly, so increased number of platelets occurs. So to destroy those platelets, to destroy the RBCs, spleen enlarges and splenomegaly also occurs. So secondary polycythemia and polycythemia vera must be differentiated. The majority of patients with polycythemia vera have JAK2 mutation, rendering hematopoietic stem cells more sensitive to growth factors. So JAK2 mutation sensitizes the hematopoietic stem cells to be more responsive to growth factors. Done. Next point is about polycythemia vera again. So it is a myeloproliferative disorder characterized by uncontrolled RBC production. Virtually all patients with polycythemia vera have mutation in JAK2 or non-receptor cytoplasmic tyrosine is a cytoplasmic non-receptor cytoplasmic tyrosine kinase associated with the EPO receptor. So erythropoietin receptor comes and binds to the receptor on the surface of RBCs and sort of hematopoietic stem cells because of JAK-STAT pathway, and there is phosphorylation of several enzymes inside the cell, and rapid multiplication of the cell occurs, causing polycythemia vera. So LR means leukomoid reaction is a benign leukocytosis. So benign leukocytosis, leukomoid reaction is a benign leukocytosis. So malignant leukocytosis means the leukocyte number of WBC is more than a very unprecedented level, but during leukomoid reaction, so there is a mild number of increase in WBC, that is 50,000, more than 50,000, that are in response to underlying conditions such as severe infection, hemorrhage. So because of severe infections, because of severe hemorrhage, malignancy, leukemia, or acute hemolysis. So because of all of them, leukomoid reaction occurs, but lab levels are normal, or peripheral smooth LAP means leukocyte alkaline phosphatase. So the number of WBCs are normal, the number of enzymes in the body also normal. So alkaline phosphatase are normal, or increased peripheral smear. So peripheral smear can show increase in band cells. So band forms are more early mature neutrophil precursor, that is myelocytes number increase, and granules, which are called Dohle bodies in the neutrophils, are also present. So peripheral smear. So peripheral smear shows increase in number of band cells, early mature neutrophil precursors. So neutrophils, despite being immature, are released in the bloodstream. So they contain some granules called Dohle bodies in the neutrophils, and that is what leukomoid reaction so leukomoid reaction is a kind of benign leukocytosis, that is more than 50,000 cells per millimeter cube, that occurs in response to an underlying infection conditions such as severe infection, severe hemorrhage, but lab levels are normal. So leukomoid reaction, lab levels are normal. Leukocyte alkaline phosphatase levels are normal, and they also show increased number of band cells, early immature neutrophils with Dohle bodies. In multiple myeloma, neoplastic plasma cells synthesize a large amount of monoclonal immunoglobulin. So plasma cells, so it's a benign, it's a proliferation of plasma cells. So malignant neoplastic plasma cells synthesize a large number of plasma cells. The function of plasma cells is to produce immunoglobulins, so large number of monoclonal immunoglobulins, not just IgG, but Ig, specific type of immunoglobulins are produced more in number, and those increased number of immunoglobulins cause the symptoms of multiple myeloma. That cells are particularly susceptible to those cells are therefore particularly susceptible to proteasome inhibitors. So proteasome inhibitors. So these cells have multiple number of proteasomes. So the proteasome inhibitors are very susceptible. Multiple myeloma cells, neoplastic cells, plasma cells are mostly sensitive to proteasome inhibitors due to large number of proteins that they manufacture. So proteasomes help in synthesis of proteins. So proteins are immunoglobulins. So globulin is the protein. So more number of proteins. So protein synthesis occurs rampantly or rapidly and rampantly, and in a high frequency in those cells. Therefore, proteasome inhibitors effectively act in the multiple myeloma cells. So the resulting accumulation of toxic intracellular and proactive proteins in the cellular apoptosis. So proteasome inhibitor decreases the number of protein synthesis. So however, protein synthesis cannot occur, but pro-apoptotic protein synthesis inside the cell, and pro-apoptotic proteins are toxic. So toxic intracellular and pro-apoptotic proteins increase, causing cellular apoptosis. So cellular apoptosis occurs. All right. Okay. To kill those cells, plasma cells, proteasome inhibitors must be given. So, what are the examples of proteasome inhibitors? So it's kind of a little bit difficult. However, I'll try to answer it by searching on Google. Proteasome inhibitors. So proteasome inhibitors. The number of some examples include uh, include bortezomib. So bortezomib is bortezomib is such an important proteasome inhibitor, and proteasome inhibitor example bortezomib. Okay, HER2 is that HER2 means human epidermal growth factor receptor 2. Human epidermal growth factor receptor 2 is a tyrosine kinase receptor that is overexpressed in 20% of breast cancer patients. In such patients, HER2 blockade with the monoclonal antibody trastuzumab downregulates cellular proliferation and promotes apoptosis. So, if HER2 is a tyrosine kinase kind of receptor, so in breast cancer patients, more than 20% of those patients have overexpression of HER2 receptors on the cell surface, and trastuzumab has a robust response against those bad breast cancer patients. So TTP1, so thrombotic uh, thrombocytopenic purpura. So thrombocytopenic purpura. So there is less number of platelets causing purpura. Therefore, thrombocytopenic purpura makes sense. And thrombotic means there is increased chance of thrombin formation as well. So is one of several primary TMAs. So microangiopathy. So TTP and TMAs. So what is TTP? What is TMA? So I think I'm a thrombotic microangiopathy. So TMA means thrombotic microangiopathy. So thrombotic microangiopathy. So TTP is one of several primary thrombotic microangiopathy resulting in MAHA means microangiopathic hemolytic anemia and thrombocytopenia, which is essential to the diagnosis. So TTP is several different kinds among the different kinds of thrombotic microangiopathic anemia. So thrombotic microangiopathic anemia, TTP means thrombotic thrombocytopenic purpura is results in thrombocytopenia, which is in the name itself, and thrombotic means there is some thrombocyte formation as well. Plasma exchange therapy has promoted more rapid diagnosis and is life-saving. So plasma exchange therapy. So those patients, the plasma from those patients with thrombotic thrombocytopenic purpura. So there is decreased platelets and there is more chance of thrombus formation as well. Both of them are taken out and more another healthy plasma is given. So this is more rapid. It helps a more rapid diagnosis and is life-saving as well. Thrombotic thrombocytopenic purpura occur results from impaired function of 1 factor cleaving protein ADAMTS13. So 1 cleaving 1 factor. So BWF cleaving factor protease is ADAMTS13. So there is 1 factor. It can be cleaved by a protein which is ADAMTS13. So it is generally deficient in thrombotic thrombocytopenic purpura. Therefore, there is no cleavage of bone factor. So bone factor multiples are not cleaved. So that is therefore it results in more coagulation or more thrombotic state. Prothrombosis occurs, cause more diffuse microvascular thrombosis. So microvascular thrombosis occurs, MAHA occurs, MAHA. So MAHA means microangiopathic hemolytic anemia and thrombocytopenia. All three of them occurs in TDP. So TDP occurs because of lack of breakdown of BWF multimers by the protease called ADAMTS13. So this therefore it causes a more thrombotic state and diffuse microvascular thrombosis. MAHA means microangiopathic hemolytic anemia and thrombocytopenia as well. So vomiting is reflex regulated mainly by 5 receptors including M1 receptor. So M1 means hyoscine effectively acts against vomiting because it acts on the M1 muscarinic receptor. D2 so D2 receptor present in the stomach are also responsible for vomiting. Therefore dopamine or metoclopramide, both of them help in preventing vomiting. H1 antihistaminic property is also showed by anti-H1 receptors, the M1, D2, H1. So M1, H1, D2, 5-HT3 serotonin receptor, onacetron, and 5-HT5 ST, and NK1 means anakinra. So not anakinra, but eprimilast. Okay, so NK1 receptor also helps in or also regulates vomiting. So 5-HT3 and NK1 receptor antagonists are particularly used for chemotherapy-induced vomiting. So for chemotherapy-induced vomiting, ondansetron can be used. Means ondansetron can be used in chemotherapy-induced vomiting, as well as NK1 receptor antagonists can also be used. Okay, because they are present centrally, and chemotherapeutic drugs usually act in the central part to induce vomiting. Therefore, these are effective. Rivaroxaban, a factor 10A inhibitor. So there is 10A in the name itself. Is an anti-oral and is an oral form. So it is available in oral form that directly inhibits factor 10A. It is used in atrial fibrillation, and venous thromboembolism. So fibrillation, which forms some thrombus and the resulting embolism, like venous thromboembolism. Both of them can utilize rivaroxaban for the treatment. Okay, so HCl, HCl. So hairy cell leukemia. Hairy cell leukemia is an indolent B cell neoplasm predominantly found in middle-aged men. So in the middle-aged men, hairy cell leukemia can occur and characterized by bone marrow failure and infiltration into the area. So hairy cells, those hairy-looking cells, go inside the bone marrow and infiltrates it, causing massive bone marrow as well as spleen, therefore causing massive splenomegaly can occur. Other typical features include a dry tap, unsuccessful bone marrow aspiration, and the presence of lymphocytes with cytoplasmic projections. So those are hairy cells. So cell membrane have cytoplasmic extensions, projections which make them look like hairy cells, and there's a dry tap because those hairy cells infiltrate into the bone marrow, therefore resulting in dry tap, and massive splenomegaly is also one of the outcome. So the next point is about imaging of bone mets. So imaging of bone mets assist in cancer diagnosis. So the imaging of bone mets assist in cancer diagnosis. Bone mets are characterized. So if there are metastases from the into the bone, like in the lumbar vertebra from various tissues, then there is it can be osteolytic or osteoplastic. So bony pain in an older man with osteoblastic lesion, if there is more osteoblastic, formation of more bony cells in the affected metastatic area, then it is more likely that the patient has suffered from prostate cancers, because it produces osteoblastic lesion, while osteoplastic lesion as generally seen in breast cancers and also in multiple myeloma. Okay, so INS means isoniazid inhibits vitamin B6 PK. So vitamin B6 PK. So INS inhibit vitamin B6 PK. B6 PK. What is vitamin B6 PK? Okay, anyways, so it inhibits vitamin B6, B6. So it inhibits B6, therefore there is no vitamin B6. Vitamin B6 active form is the cofactor for delta ALA. So delta ALA synthase. So for the formation of delta ALA synthase, which is required in the heme synthesis pathway in the early cycle, where glycosaminoglycan and glycine combine to form ALA. So ALA synthase requires a cofactor, which is vitamin B6. So vitamin B6 deficiency causes less formation of delta ALA. So that catalysis of which is the rate limiting step of heme synthesis. Inhibition of this step can result in sideroblastic anemia. So sideroblastic anemia occurs because of INS. So INS INS, so that is isoniazid, inhibits vitamin B6. Therefore, ALA synthesis step is inhibited, downregulated, and therefore it results in sideroblastic anemia. Gaucher's disease. Gaucher's disease is autosomal recessive lysosomal storage disorder that's characterized by beta-glucocerebrosidase deficiency. So Gaucher's disease has a deficiency of an enzyme. So Gaucher's disease has a deficiency of an enzyme, which is beta-glucocerebrosidase. So beta-glucocerebrosidase deficiency occurs in Gaucher's disease and presents with pancytopenia and hepatosplenomegaly. So Gaucher's disease is characterized by hepatosplenomegaly, and all three cell lineages are affected. That is, pancytopenia occurs. Glucocerebrosidase accumulation leads to distended macrophage with a wrinkled tissue paper appearance, that is Gaucher's cell. So if there is deficiency in the enzyme glucocerebrosidase, so gluco means glucose, that helps in the formation of that helps in cerebral development, let's say. So glucocerebrosidase accumulation leads to distended macrophage. Macrophage now becomes distended or swollen with wrinkled tissue paper appearance, which are called Gaucher's cells. So what are Gaucher's cells? Gaucher's cells are distended macrophage with a wrinkled tissue appearance, and it occurs in a disease called Gaucher's disease, which is lysosomal storage disease, where beta-glucocerebrosidase enzyme is deficient, leading to hepatosplenomegaly and pancytopenia, and Gaucher's cell formation, that is macrophage enlarged with wrinkled tissue paper appearance. All right, PNH. So PNH is paroxysmal nocturnal hemoglobin rise due to a gene defect, PGA gene, that leads to uncontrolled complement-mediated hemolysis. So complement-mediated hemolysis especially occurs during sleep because of a relative anoxic state or hypoxia state during sleep, and PGA gene that codes for protein DAF, that is deactivating factor, which helps in cleaving or making the complement proteins inactivated, is deficient. Therefore, there is uncontrolled activation of complement proteins, and therefore hemolysis occur, and especially at night, resulting in nocturnal hemoglobinuria. The classical sites triad includes hemolytic anemia. So there is due to complement attacks RBCs, resulting in hemolysis of RBC, causing hemolytic anemia, or from where hemoglobinuria goes into the urine, causing the urine to turn black in color, as well as pancytopenia. So because of complements, not only just does not attack RBC but WBC and platelets as well. Therefore, pancytopenia occurs and thrombosis occurs at atypical sites. Thrombosis occurs at the atypical sites. Chronic hemolysis can cause, if there is chronic hemolysis, so if there is chronic hemolysis, it can cause iron deposition in the kidney, that is hemosiderosis. Iron deposition can occur in the kidneys, causing hemosiderosis. All right. Now, what's telomerase? Telomerase is one of the very fascinating scientific breakthrough or discovery. Let's say telomerase is an RNA-dependent DNA polymerase. So there's a DNA polymerase which depends on RNA. So DNA-dependent RNA polymerase that synthesizes telomeric DNA sequence that can replace the lost chromosomal ends of the telomeres. So it's the DNA polymerase. DNA depends on RNA. So DNA polymerase, which is RNA-dependent, which helps the formation of telomeric DNA sequence at the last chromosome that can replace the lost chromosome ends of the chromosome. So if the telomeres has lost, if the chromosomes at the last, that is last loses some part of chromosomes, then those telomeres are replaced by telomerase. Cancer cells typically contain increased telomerase activity to allow for continued proliferation. So they have increased telomerase activity, which helps in increasing the number of cellular replication cycle. All right, sickle cell disease is a result of missense mutation that cause valine to replace glutamic acid. So glutamic acid is replaced by valine at position 6 in the hemoglobin beta globin chain. RNA contains the pyrimidine base uracil, while DNA contains thymidine. So it's a very well-known fact. So the binding of PD-1, so PD-1 of its ligand PD-L1 down-regulates the immune response by inhibiting TC cells. So cytotoxic T cells. So the down immune response by cytotoxic T cells occur. Why does not the immune system attack cancer cells? Because the cancer cell overexpresses some protein called PD-1, so PD-L1. So there is PD-1 proteins in the cancer cells which bind to the PD-1. That is, so there is a kind of a break protein, PD-1 ligands present in the immune cells. That is especially in the cytotoxic immune cells, T cells, and this time, so the immune cell does not destroy the cancer cells. Many types of cancers evade immunodetection by increasing the expression of PD-L1 on their surface. PD-L1 on the surface. So monoclonal antibody against PD-1, for example, pembrolizumab, upregulates the T cell response and promotes tumor cell apoptosis. All right. So activity mutations of the KRAS gene leads to constitutive activation of the EGFR pathway. So if there is mutation, so activating, so KRAS, so KRAS, if there is KRAS gene activation, then it leads to constitutive activation of the EGFR pathway. So EGFR pathway, epithelial growth factor receptor pathway, is activated, promoting increased cellular proliferation and growth. So increased cellular proliferation and growth occur. Tumors harboring these mutations are resistant to treatment with anti-EGFR drugs. So if there is cellular proliferation. So for cells to proliferate, EGFR, that is a growth factor, is necessary. So growth factor EGFR is controlled by an activity mutation of the KRAS gene. Okay, tumor which harbor these mutations are resistant to treatment with anti-EGFR drug, because EGFR is not the inhibition of just EGFR is not sufficient. That is cetuximab, panitumumab, cetuximab. So cetuximab, panitumumab, So these all are anti-EGFR drugs. Why? But they does not act against these cancers which have KRAS gene activation mutations. Okay, the ubiquitin proteasome pathway mediates targeted protein degradation, which allows for rapid disposal of unneeded intercellular proteins. So ubiquitin proteasome pathway mediates targeted protein degradation. So ubiquitin proteasome pathway mediates targeted protein degradation. So it degrades some proteins into the cells, which allows for rapid disposal of unnecessary intercellular proteins. So they are unnecessary. They are inside the cell. Some proteins are necessary. Sometimes they are not. So if the proteins are not necessary, then ubiquitin proteasome pathway activates, which targets the unneeded, unnecessary intercellular proteins. So in cancers related cachexia, high levels of pro-inflammatory cytokines leads to high ubiquitination of sarcomeric protein, sarcomeric muscle protein. So, okay, that's very, interesting. That's very interesting. Now, see, there is high amount of proteins of these cytokines in the cells in the patients with cancers. So those cancer cells leads to the high number of cancer cells, the high number of pro-inflammatory molecules in the cancer patients leads to high ubiquitination of sarcomeric muscle proteins. So the muscle proteins are considered unnecessary by the ubiquitin proteasome pathway, so they destroy the sarcomeres, resulting in weight loss, which leads to extensive skeletal muscle loss. All right. Now, primary myelofibrosis is a myeloproliferative disorder associated with the clonal expansion of megakaryocytes. Okay. And so PMF means primary myelofibrosis is an myeloproliferative disorder with clonal expansion of megakaryocytes. Megakaryocytes are clonally expanded, increased number of platelet occurs. Bone marrow fibrosis accounts for the most of the major manifestations. So bone marrow fibrosis is the result for majority of manifestations, including hepatosplenomegaly, cytopenias, and blood smear evidence of dacrocytes. So dacrocytes are seen. Number one. So in primary myelofibrosis, say myelo means bone marrow, fibrosis means fibrosis. So fibrosis occurs in the bone marrow. Bone marrow fibrosis occurs at the main manifestations, including so because of bone marrow fibrosis to for the production extramedullary hematopoiesis, that is hepatosplenomegaly occurs for extramedullary hematopoiesis. Cytopenia occurs because of bone marrow disruption and blood smear shows dacrocytes. Bone marrow aspiration is usually dry because of fibrosis, but bone marrow biopsy will show marked fibrosis with occasional cluster of atypical megakaryocytes. See, so there are atypical megakaryocytes inside the bone marrow, so therefore bone marrow biopsy reveals cluster of atypical megakaryocytes. All right, bleomycin is an anti-neoplastic agent that binds to iron and oxygen molecule to create free radicals that cause DNA strand break. So bleomycin causes, you know, is an anti-neoplastic agent that binds to iron and oxygen molecule binds together to create free radicals that cause DNA strands break. So DNA strand breaks. Most clinically important of adverse effect of bleomycin is long toxicity with pulmonary fibrosis, which causes dyspnea because of fibrosis in the lungs. Dyspnea occurs, and NPC. NPC means nasopharyngeal carcinoma. So nasopharyngeal carcinoma is also a side effect of bleomycin, and PFT shows restrictive pattern because of with decreased DLCO. So diffusion capacity of carbon monoxide. So diffusion capacity of DLCO decreases. Restrictive pattern of PFT occurs. So okay, so FEV1 decreases, FVC also decreases, and DLCO also decreases in bleomycin toxicity. Alright, cancer cells avoid immune recognition by overexpression of PDL1, which binds to the PD1 receptor on T cells. So PDL1 is a ligand present in the cancer cells, while PD1 receptor is present in the T cells. Cytotoxic T cells and inhibit the response T cell exhaustion occurs. Monoclonal antibody that block PDL1 and PD1 are effective against carcinoma that express high levels of neoantigens on the surface because these tumors are particularly susceptible to immune recognition by cytotoxic cells. This was already understood. Next point is about target cells. So target cells form when erythrocytes have decreased cell volume. That is, so if there is a decrease in cell volume, that is thalassemia, iron deficiency. So when there is decrease in cell volume, that is when the water is less than, target cells are formed. So target cells means they do not stay in the center, but rather stay in just the outward part, resulting in central pallor, which is the characteristic feature of target cells, or excessive membrane. So if there is excessive membrane, for example, post-splenectomy, and also patients who undergo splenectomy that usually develop target cells because the spleen is the primary organ that prunes excessive RBC membrane. So after splenectomy, then the excessive RBC membranes are pruned off by the spleens, but because of absence of spleen, then target cells can be seen. So target cells can be seen in iron deficiency anemia and excessive membrane disorders. Now, SIT. So SIT means heparin-induced thrombocytopenia. So heparin-induced thrombocytopenia and thrombosis result from production of IgG antibodies against complexes of heparin and platelet factor 4. So heparin and platelet factor 4, SIT is type 1 and type 2. So type 2 is immune mediated, that is immune complex forms between heparins and platelet factor 4. The Fc segment and components of these antibodies bind to platelets. So Fc component of these antibodies, IgG antibodies, bind to platelets, resulting in widespread platelet activation and prothrombotic state. So SIT results in thrombocytopenia because of platelet factor 4 is bound to heparins, and it is an immune mediated mechanism. but type 1 is a non-immune mechanism. Okay, that was a very important point. Now, multiple myeloma is suspected to be suspected in elderly patients who have combo of osteolytic lesions, hypercalcemia, anemia, or AKI. Renal disease is most commonly caused by LC light chain cast nephropathy, in which free liver light chains form obstructive cast in the renal tubules. Free light chains form cast in the renal tubules. Monoclonal paraproteins are not detected by urine dipstick, which only detects albumin. So you see monoclonal paraproteins. There are immunoglobulins. There are other several kinds of proteins which are not detected by dipstick because dipstick only detects albumin, but both spot and 24-hour protein concentration will be increased. All right, makes sense. Multiple myeloma is a plasma cell malignancy with pure radiolucent bone lesions due to stim of osteoclast and inhibition of osteoblast. So stimulation of osteoclast occurs, therefore it results in lucent lesions, while inhibition of osteoblast also occur. Myeloma cells stimulate osteoclast level by secreting myeloma cells secrete rank ligand and destroys the osteoprogesterin. So destroys osteoprogesterin and stimulates rank ligand, which in turn stimulates more of osteoclastic activity, which increases rank activity and results in osteoclastic differentiation. So osteoblast with the rank ligand goes into the osteoclast, tick receptor, rank receptor, and thus its activity is increased. Most oropharyngeal carcinoma, base of tongue, are characterized by SPV infection. So SPV infection, SPV 16 is particularly likely to cause malignant transformation. So oropharyngeal carcinoma is caused by cervical cancer as well as oropharyngeal carcinoma is caused by oropharyngeal carcinoma is caused by SPV infection. SPV 16 is more prone. It's not more likely to cause this transformation. So primary myelofibrosis is a chronic proliferative disorder associated with myelofibrosis. EMS, that is EMS, extramedullary hematopoiesis, leads to marked expansion of the spleen, red pulp with SPO, so stem cells, progenitor cells. So splenic red pulp increases. So you see there is hematopoiesis. So RBC has to increase. Red pulp in the spleen has RBC forming stem cells or SPO progenitor cells. Stem here HSC progenitor cells. So progenitor cells and result in massive splenomegaly. So splenomegaly occurs in primary myelofibrosis. Pulmonary is destroyed. So it has more of megacardiocytes, therefore more of splenomegaly occurs, massive splenomegaly occurs. Patients also usually have hepatomegaly, cytopenia, and PBS abnormalities. For example, dacrocytes are seen, tear cells are seen. Dacrocytes means tear cells. Nucleated RBCs are seen, immature granulocytes, nucleated RBCs, and dacrocytes, all of them are seen in the peripheral blood smear. ALL. So ALL is marked. By a high concentration of circulating lymphoblasts. So acute lymphoblastic leukemia has high concentration of lymphoblast in the bloodstream. So circulating lymphoblasts are present in ALL. Flow cytometry can be used to distinguish between B cell and T cell. So all of B cells have CD19 expression, while T cells have CD3 expression lineages. T cell ALL usually arises in teens or individuals in their 20s. T cell arises in the individuals in their 20s on of presence with large mediastinal. So how do you differentiate them? So you see differentiation between T cells and B cells can be done by T cells. So T cells have a marker called CD3, while B cells have CD19 on cell surface. Also, mediastinal mass is more commonly seen because of thymus, where T cells mature. Also enlarges, therefore T cell thymus enlargement mediastinal mass is seen in T cell lymphoma ALL, while not in BAL. So TLL arise in teens or individuals in their 20s. So T is for teens, T for 20s. So T cell ALL occurs usually in teens or individuals in their 20s. Okay, so CDK4/6. This is some kinase activity. It regulates CDK4 or 6 regulate the movement of cells from G1 to S phase. So G1 checkpoint is regulated by something called CDK4/6. So cancers most often have mutation that enhances the activity or downstream effects of CDK4/6. So cancers often have mutations that enhance the activity or downstreams effects of CDK4/6. So cancers has to undergo several multiplication, and therefore has to undergo more cell cycle steps. So it's a G1 checkpoint is prevented by stimulating more of CDK Okay, CD4K, CDK4/6 regulates the movement of cells from G1 to S phase. Cancer's most of mutation that enhance the activity downstream effect of CD4/6, which contribute to unregulated cellular growth. Okay, inhibition to CDK or 6 can be used to treat certain forms of cancer. However, they can inhibit cellular replication in other rapidly dividing cells, such as heme cells, the bone marrow, this causing neutropenia, anemia, or thrombocytopenia. So, you see, CDK inhibitors can be used as as drugs for control for CDK inhibitors can be used. Okay, CDK allows G1 exports input checkpoint to G1 checkpoint to to escape. So therefore, CDK inhibitors, 4/6 inhibitors, can be used in cancer treatment. So, however, some rapidly dividing cells are also affected because, like bone marrow, causing pancytopenia. Okay, so fish. So, fluorescent immune something histochemistry. So, in situ hybridization. So, fluorescent in situ hybridization can identify. So fish can identify small specific chromosome translocations. So 8, 12, 8, 14, 12, 15, 17, all sorts of chromosome translocation can be identified by fish. Duplications or deletions. So duplications can also be identified. Deletions can also be identified using a complementary ssDNA segment that's tagged with a radio tracer. So ssDNA segment. ssDNA segment, using complementary ssDNA segment that's tagged with a radio tracer. So radio tracer, so there is a single stranded DNA segment. So see, this is a single stranded DNA segment. It has something tagged in it. It is the radio tracer. Radio tracer. So this DNA segment with the radio tracer can help in detecting chromosome translocations, duplications, or deletions. So fish is a rapid, highly sensitive and specific, and can be used on tissues with low mitotic rate. So even those tissues which have low mitotic rate can also be identified for any presence of any translocations, duplications, or deletions by using this technique. However, targeted chromosome abnormalities must be somewhat large. So targeted chromosome abnormality must be somewhat large in order to be identified. So the targeted chromosome must be somewhat large to identify the particular translocation, duplication, or deletion. So FISH is a technique to detect chromosome translocation, and it has some single strand DNA with a radio tracer. Yeah, that's how FISH identifies the translocations. Okay, so erythropoietin. So erythropoietin is produced by peritubular fibroblast cells in the renal cortex. So erythropoietin is produced by renal cortex. We have said it earlier, but there is in the renal cortex there is the cells which surround the tubules. So peritubular fibroblast cells are present in the renal cortex in response to decreased renal oxygen delivery. So when there is renal hypoxia, then cortical cells which has peritubular which specifically peritubular fibroblast, peritubular fibroblasts produce erythropoietin, so it acts as erythrocytic precursor in the bone marrow to increase RBC production. So EPO acts on erythrocytic precursors and therefore increase RBC production. Patients with CKD often have damage to renal EPO cells. So CKD patients have damage to peritubular fibroblasts, therefore EPO is not produced, resulting in anemia. So anemia means anemia is produced, which is normocytic in nature. So normocytic in nature, not microcytic, because there's not any DNA damage. There's no any, there's no any lack of any substrate for the production of RBCs. Therefore, normocytic anemia occurs in CKD patients. CKD is commonly associated with normocytic anemia due to reduced production of EPO by the kidneys. EPO signal transduction is primarily mediated by the JAK-STAT pathway, activation of JAK2-STAT pathway, which promotes erythrocyte precursor survival. So erythrocyte precursors survive because of by utilizing the pathway called JAK-STAT pathway. So it's a JAK-STAT pathway. So erythrocyte precursors survive because of JAK-STAT pathway, and CKD is associated with anemia, normocytic anemia, because of decreased EPO secretion by the kidneys. Melanoma. So now let's talk about melanoma. Melanoma is a highly aggressive malignancy that often meets early in the stage. So melanoma is a highly aggressive melanoma. So melanoma is very dangerous. Okay, highly aggressive malignancy that often meets early in the disease course. Patients may be symptomatic for years prior to onset of metastatic manifestations. Diagnosis is generally made when a histopathological sample shows cellular atypia. So patients may be asymptomatic for years prior to onset of metastatic manifestations. Diagnosis is generally made when a histopathological sample shows cellular atypia. So diagnosis, how does okay, so metastatic, before metastasizing, there are the kinds of, even the metastasis can be asymptomatic. So when menstruation occurs, only symptoms can be seen. Diagnosis is made when histopathological sample shows cellular OTP. So there is cellular OTP with cells containing brown pigment, which are melanin granules, and they are S100 and HMB45 positive. So immunostaining with melanoma markers, which is S100 and HMB45. S100 and HMB45 is generally positive. So next page. Multiple myeloma is the chronic proliferation of plasma cells in the bone marrow. This prevents normal B cell lymphocytosis and increases the risk of bacterial infection due to decreased production of normal immunoglobulins. There is high proliferation of plasma cells in the bone marrow. So there is high production of plasma cells in the bone marrow. So there are more production of plasma cells, but normal B cell lymphogenesis does not occur. Therefore, B cells cannot produce functional immunoglobulin cannot be produced. And hence, bacterial infection increase because of decreased production of functional immunoglobulins. Okay, multiple myeloma is a plasma cell malignancy that replicates in the bone marrow and causes osteolytic bone lesions. So multiple myeloma is a plasma cell malignancy that replicates in the bone marrow and causes osteolytic bone lesions, bone destruction, hypercalcemia, and pathological fractures. So multiple myeloma causes osteolytic bone lesions that was discussed before. Hypercalcemia, pathological fractures, histopathological source, replacement of normal bone with plasma cells and plasma blasts. So plasma cells and plasma blasts fill up the bone marrow. Now let's talk about hemophilia. It is an X-linked disorder associated with deficiency of factor 8. So factor 8 and factor 9 are deficient. So emicizumab, a biospecific monoclonal antibody, mimics the activity of factor 8 by binding to both factor 9A and factor 10. So factor 9A in right hand and factor 10 in left hand are bound together. They are brought closer into a closer proximity to allow for factor 10 activation. So factor 10 activation occurs by a drug which is emicizumab. So emicizumab is a drug that helps in binding factor 9A and factor 10. So factor 8 replacement can be done by emicizumab. All right, again. Now let's talk about CLL. So CLL is a chronic LPD. So CLL is a chronic LPD marked by is a chronic LPD. So it's a chronic LPD marked by the progressive accumulation of mature B cells. So there are because it is chronic. So mature B cells proliferation of accumulation occurs. So mature B cells accumulate. Most patients are asymptomatic for years, but eventually develop anemia, thrombocytopenia with neutropenia. So pancytopenia can occur in patients with CLL. So CLL pancytopenia can occur in patients with CLL. The diagnosis is generally made when CBC reveals dramatic leukocytosis. So CBC reveals a dramatic form of leukocytosis. So there's increased WC count, and FC subsequently shows a clonal population of leukocytes with atypical B cell markers like CD19, 20, and 23. So B cells with typical B cell marker like 10, 20, 23. Sorry, it's typical. So 9, 20, 23, 19, 20, 23. So these are typical B cell markers. So B cell markers, therefore these the B cells from lymphoblasts. So CLL, there is accumulation of mature B cells marked by its markers like say 19, 20, and 23. And diagnosis is generally made when CBC reveals a large number of leukocytes, but there is anemia, thrombocytopenia, and neutropenia. So there is higher chance of infection. Okay, parvovirus B19. So parvovirus B19 infection can cause transient aplastic crisis. So aplastic crisis can occur in parvovirus B19 infection. So particularly in those with underlying hemoglobin disorders such as SCA. So SCA in sickle cell disease, sickle cell anemia, PBB, parvovirus B19 infection occurs. Patients develop signs and symptoms of anemia, that is exertional dyspnea, fatigue, and low hematocrit. So low hematocrit is a sign of anemia. So low hematocrit is a sign of anemia due to inhibition of erythropoiesis by the virus. So parvovirus B19 inhibits erythropoiesis. So it goes into the bone marrow. So parvovirus goes inside the bone marrow, targets the premature erythrocyte or hematopoietic erythrocytic cells and decreases erythropoiesis. So bone marrow examination will show giant pro-normoblast. So bone marrow examination. So bone marrow examination, when bone marrow biopsy is done, then what do we see? We see normoblast. So there is normoblast cells. Actually, not normoblast but pro-normoblast with glassy intranuclear viral inclusions. So inside the nucleus of those normoblasts, so inside the nucleus of those pro-normoblast, there is intranuclear viral inclusions. There's glassy intranuclear viral inclusions. Glassy intranuclear viral inclusions are seen. Okay, so now let's talk about Ewing sarcoma. So Ewing sarcoma, paraspinatin has internuclear inclusions. Okay, Ewing sarcoma is the second most common malignant bone tumor of childhood. So second most common malignant bone tumor of childhood after osteosarcoma. It most commonly involves Ewing sarcoma, the second most common malignant tumor, bone tumor. So most after you see the most common malignant tumor of childhood is osteosarcoma. After and second most common is Ewing sarcoma. It most commonly involves the lower extremity and pelvis. So lower extremities like legs, legs, hind foot, and pelvis are often metastasizes to lungs. So it can metastasize easily to lungs. Histopathological pathology is characterized by uniform small round cells, or they're round small cells, fibrous septa, and patches of necrosis and hemorrhage. So hemorrhage and necrosis patches are seen along with fibrous septa and small round blue cells. Okay, so osteosarcoma is most common primary bone malignancy in children and young adults. It occurs most frequently at the metaphysis of long bones. Osteosarcoma occurs in metaphysis of long bones with local pain and swelling. Most cases are associated with sporadic or inherited mutations in RB1S, RB, and TP53, Li-Fraumeni syndrome. So osteosarcoma is associated with mutations. So osteosarcoma, which is the most common primary childhood malignancy, in childhood malignancy or in the young adults, and there is mutation, sporadic or inherited mutation in RB, retinoblastoma 1, SRB, and TP53. So RB and P53. So these mutations occur. Chemotherapy-induced nausea and vomiting is mediated by pre and central mechanisms. It can be treated with ondansetron 5-HT3 antagonist to prevent fiber stimulation of afferent vagal fibers in the bowel wall. So peripheral cause and NK1 receptor antagonist or prepitant to prevent effects of substance P in the brainstem. So vomiting occurs by substance P that stimulates the vomiting center in the brainstem. So and vomiting substance P can be inhibited by or prepitant, while peripheral bowel has vagal fibers which are stimulated by 5-HT3. Therefore, it decreases the chance of vomiting as well. Okay, CLL is associated with overexpression of BCL2. CLL, chronic lymphocytic leukemia, is associated with overexpression of BCL2, which is an anti-apoptotic protein on the mitochondrial membrane. Treatment with BCL inhibition causes cancer cell death. So when BCL inhibits, then cancer death occurs because anti-apoptotic features is becomes absent, and there is cell death by promoting cytochrome C release from the mitochondria, which subsequently activates caspases. So caspases are activated, and there occurs apoptosis. So CLL is associated with BCL2 expression. CLL is associated with BCL2 expression. Vitamin B12 is an essential cofactor in the recycling of 5-methyl tetrahydrofolate to tetrahydrofolate. So vitamin B12 is necessary. So there is a vitamin which is vitamin B12. So there is 5-methyl tetrahydrofolate. So 5-methyl tetrahydrofolate converts to tetrahydrofolate. 5-methyl is removed. Methyl is removed, goes to methionine, goes to homocysteine forming methionine. So 5-methyl tetrahydrofolate converts to tetrahydrofolate, which is required for amino acid purine and thymidine synthesis. So THF is required. So THF helps in thymidine synthesis, purine synthesis, and amino acid synthesis. So amino acids, that is proteins, purines, and thymidine synthesis occurs. Deficiency primarily affect the SPO cell maturation. So DNA are not mature. There is discrepancy in nuclear cytoplasmic maturation. SPO cell maturation does not occur, marked by increase in nuclear cytoplasmic ratio. So NC ratio increases, and it leads to then it leads to increased NC ratio, leading to macrocytic RBC with hypersegmented neutrophils. Increased apoptosis often also leads to anemia and mild thrombocytopenia or leukopenia. So anemia or pancytopenia occurs. Simply pancytopenia occurs, megaloblastic anemia occurs. So that's it. Now let's talk about acute DIC, disseminated intravascular coagulation. Is a congenital coagulopathy linked to severe trauma. Widespread formation of microvascular thrombi leads to consumption of platelet coagulation factors and fibrinogen. Subsequent activation of coagulation proteins leads to low protein CS. So there is low protein CS. Fibrinolysis occurs, and which produces more number of D dimers. Most patients have bleeding complications oozing from vein of puncture sites, and EOD to lungs or kidneys. Bleeding complication occurs. So it is a very well-known fact. DIC is marked by widespread activation of coagulation cascade leading to excessive factor 2A production. So there's more thrombin activation. So thrombin activates and forms microthrombi. Subsequent conversion of plasminogen to plasmin results in increased fibrinolysis. So plasminogen also converts to plasmin. So there is plasmin causes fibrinolysis to clear the thrombi. So to clear those thrombi which are produced because of activation factor 2A, plasmin is formed. Plasmin forms or breaks down the thrombi and produces D dimers. Fibrinolysis occurs and D dimers are increased. So lab source of consumption of clotting factors. So prolonged PTI occurs, platelet thrombocytopenia occurs, and increased D dimer is also seen. Von Willebrand disease is most common in inherited bleeding disorder and is usually transmitted in an autosomal dominant fashion. Signs and symptoms patients typically present with easy bruising and mucosal bleeding. Lab will show normal platelets because the number of platelets is not disturbed. Normal PT and normal PT extrinsic pathway is not disturbed, and either normal or prolonged epidemiology of low levels of factor 8. So factor 8 is disturbed, so factor 8 is involved in intrinsic pathomechanism, so epidemiology can be increased. Thank you, guys.